Thank you very much for inviting me to be with you today, and I'm sorry that I can't be with you in person, but I'm delighted to have this opportunity to speak to you, and I thank the organisers for asking me, and I hope everyone's having a good meeting. My name's Paul Monagle, and I'm from Melbourne, and I'm going to talk to you today about DOACs in children. My disclosures, I have no financial disclosures at all. I don't take money from any pharmaceutical companies. I have been involved at a steering committee level of the Einstein Junior and the saxophone studies, and have also enrolled patients into the canine studies. My research team has received research support from a number of companies, but none of which is directly relevant to today's discussion. I just want to remind you all that before all of the current DOAC studies came along, the amount of information that we had about anticoagulation in children was really minimal. This was the data from the American Society of Haematology VTE guidelines that we published in 2018. And what it showed, for example, was that for VTE treatment, we only had 36 children who had been involved in an RCT exposed to low molecular weight heparin, and 40 children that had been in an RCT exposed to vitamin K antagonists in children. So the RCT data supporting our standard of care was minimal prior to the DOAC studies. Over the last few years, however, we've had large paediatric programs by four DOACs: dabigatran, rivaroxaban, edoxaban, and apixaban. And each of them has run a sequence of studies looking at a number of different things. When we think about it in terms of what the indications were, in terms of primary VTE prevention, apixaban did the Prevapix ALL study, which I'll come to. In terms of cardiac prevention, apixaban, edoxaban, and rivaroxaban have all done studies of cardiac prevention. And then in terms of VTE treatment or secondary prevention, all of the drugs have been involved in those studies, but not all of them have been completed yet, and I'll come back to that. Both rivaroxaban and and dabigatran are now approved for use in the United States, UK, and the European Union in children. So just starting with the Einstein Junior phase 3 study, rivaroxaban compared to standard of care, large study, 335 children in the rivaroxaban arm, treated for 3 months, possibility of 12 months follow-up if required. Like all of the DOAC studies, the DOAC was not started until after at least 5 days of a heparinoid treatment after initial diagnosis, and that's important to remember. In terms of the results of the study, no difference really in recurrent VTE, no difference in mortality, no difference in major bleeding or clinically relevant non-major bleeding. So essentially, it looked like rivaroxaban is equivalent to our standard of care in terms of risk and benefits. There have now been a dozen publications out of the Einstein Junior program from the initial in vitro work through the PK data and through the results of the RCT, and then some subgroup analysis over the last year or so. The Universe study was rivaroxaban versus aspirin for primary prevention post-Fontan. And this study was a small study that initially enrolled 10 patients in a non-randomized way and exposed them to rivaroxaban in a dose that was half what was used in the Einstein Junior program, so equivalent dose to 10 milligrams once daily in adults, whereas Einstein Junior used 20 milligrams once daily in adults equivalents. After the initial cohort followed up for 12 months, they then had a randomized phase, 2-to-1 randomization in favor of rivaroxaban compared to aspirin, and again for exposure to the drug for 12 months. Interestingly, the Riva patients didn't really start their drug treatment until about 45 days post-Fontan. The aspirin started around 37 days post-Fontan. So looking at the universe study, there was the small cohort at the start and then a small number of patients, 66 with rivaroxaban and 34 with aspirin. And what's interesting in this study is the bleeding rates. You know, using half the dose that was used in the Einstein Junior program, they had almost 3 times the bleeding rates. And, you know, bleeding rates in terms of clinically relevant non-major bleeding of 6 and 8% in rivaroxaban and 9% in aspirin. So I think there was a definition problem in this study because a 9% bleeding rate on aspirin just is hard to make a lot of sense of. So when we put together all of the Riva studies that have been done, rivaroxaban studies, what are the main things that we can say? Well, you can see from this table that there has been a relatively small number of children under 2 years of age who have been exposed to rivaroxaban, only 37 children. And interestingly, CVL-associated clots only made up 27% of the study population in the Einstein Junior program, when that's usually a much higher percentage of the clots that we actually see. And of course, anyone who had any multi-system disease or was premature were excluded from the studies. So what can we say based on all of the rivaroxaban data? We can say that it's got predictable PK and PD when we administer it orally, both in tablet and liquid form. The studies were completed without routine monitoring, and so we can say there's no need for routine laboratory monitoring. And we think it's at least as effective and safe a standard of care for acute VTE treatment, for secondary VTE prophylaxis, and for thromboprophylaxis in children with Fontan. But we need to understand that the studies involved a higher proportion of older children, and there were no children with severe illness or comorbidities. If we move on to dabigatran, the diversity study, I think the main points I want to make about the diversity study is that it had a different design to the Einstein Junior. So patients, when they were enrolled and they were randomized to dabigatran, had a monitoring assay taken within a week of commencing the dabigatran. If that assay showed their plasma concentration was lower than the target that they were aiming for, the patients were allowed a single dose adjustment to adjust the dose upwards. And then if on a second test a further week later, the patient was still not in the therapeutic target range, the patients were excluded or discontinued from the study. And that happened in over 10% of the patients. So if we think about the dabigatran studies, it had similar issues to the Riva studies, very small numbers of children under 2 years of age, a high proportion of children with inherited thrombophilia, and a low proportion of CVL-associated thromboses, and once again excluded anyone who was premature, anyone with multi-system disease. So what can we say at the end of the dabigatran's paediatric program? Well, we can say it's probably got reasonably predictable PK/PD, but I don't think we can say it doesn't need laboratory monitoring, because that's not what they did in the trial. We can say that once you are therapeutic on it, then it appears to be at least as effective and safe a standard of care for acute VTE treatment and for secondary VTE prophylaxis. Once again, there were no special disease populations studied, and the studies included a higher proportion of older children. The Enobolate study, the study of edoxaban, also came out in late 2022. This study, again, was a 2-to-1 randomization to edoxaban and standard of care for prevention of clot in cardiac patients. And then patients could go on to an extension period where they received edoxaban for up to 12 months. At the end of the main treatment period, 109 children received edoxaban, 58 children standard of care, no difference in bleeding rates and no difference in thrombosis rates. So again, it would appear equivalent to standard of care as primary prophylaxis in cardiac patients. There are a number of programs that are still actually ongoing. And in particular, with apixaban, there is the saxophone trial and the Prevapix ALL trial, both of which have been completed and published and presented in abstract form, but have not been published as yet in peer-reviewed publications. The canine study has been running for a long time, and it is limited by the fact that they have completed enrolments for all age groups other than the neonatal age group, which was one of their FDA requirements. And the study has been stuck trying to recruit some very small infants for the last 2 years now, before we can actually, that study can be closed out and the data made available. Edoxaban has also had a VTE treatment study completed, but not yet published. So I mentioned that that the saxophone study had been presented in abstract form at ISTH in 2022. So it was almost 200 patients screened, 192 randomized, 129 to apixaban, 63 to standard of care. This was primary thromboprevention in children with underlying cardiac disease. And as you can see, almost 3/4 of the patients were single ventricle Fontan type patients. But there was also a number of children who had Kawasaki disease or other forms of congenital heart disease. And in terms of the primary endpoint of the study, a composite of major and clinically relevant non-major bleeding, no difference between the apixaban arm and the standard of care arm. In terms of any bleeding, there was an increase in minor epistaxis in the apixaban arm compared to standard of care. And that's, I think, relevant because when we get to the next study, which was the Prevapix ALL study, so this was a study that, excuse me, enrolled children with ALL or lymphoblastic lymphoma who were receiving induction chemotherapy with asparaginase, and it randomized them 1-to-1 to either apixaban primary prophylaxis versus standard of care, which is no anticoagulation. They had an extremity ultrasound and an echo at day 29, which was the endpoint of the study. And this involves 74 centres across 10 countries and was independent blinded adjudication. This was the dosing schedule that was used in the Prevapix ALL study, and I'll come back to the dosing schedule that was used in rivaroxaban and in Einstein Jr., and in saxophone in a second. 256 patients randomized to apixaban, of whom 198 completed treatment, and 256 randomized to standard of care, of whom 245 completed treatment. And at the end of the day, no difference in the thrombosis rate between the apixaban and the standard of care, which, remember, was no anticoagulation. And when we look at bleeding, no statistically significant difference in bleeding as well. Just as you could suggest there might be a trend to reduce thrombosis in the apixaban treated arm, there's also a trend towards increased bleeding in the apixaban treated arm. So at the end of all of those DOAC studies, what can we say so far in general? We can say that the DOACs appear to be well tolerated in children. They achieve similar drug exposures to adults, and they have some favourable clinical benefits and equivalent efficacy and safety. We can use them for treatment of acute VTE, secondary VTE prevention, and probably prevention in the setting of congenital heart disease. The populations that have been studied were heavily weighted towards older children and adolescents who were relatively healthy. young age groups were underrepresented, and premature infants and those with severe comorbidities were excluded. And so we have limited experience in specific disease populations. I think with the exception of dabigatran, we can say that routine monitoring is not necessary. But whether that is true in populations that were excluded from the trials, for example, children on long-term TPN or children with renal or liver disease, we don't know the answer to that. And the endpoints that were studied in all of the studies were straightforward endpoints: recurrent thrombosis, thrombus resolution or progression, mortality, major bleeding, clinically relevant non-major bleeding. What we haven't looked at is longer term things like post-thrombotic syndrome, and with the exception of the saxophone study, none of the studies made an attempt to address quality of life. But at the end of the day, the DOACs are now the most studied anticoagulant agents that we have in children. So this is just the dosing schedule that was used in the Einstein Junior program. And the really important thing to note here was that it was once daily dosing above 30 kilos, twice daily dosing from 12 to 30 kilos, and then 3 times a day dosing in children under 12 kilos. There is a liquid preparation for rivaroxaban, an oral suspension, and I'm unsure whether that's available for you in Saudi Arabia. For us, it's not readily available in Australia at the minute because the drug has not been licensed by the Therapeutic Goods Administration, which is our equivalent to the FDA or EMA in Europe. When we look at the apixaban dosing, we don't have the real data, or we don't have any data yet from the canine study in terms of VTE treatment because it's not completed. But in terms of what was used in the saxophone study, again, it was a twice daily regime across all of the age groups, and then with a weight-adjusted regime. The important thing to know is that while an oral preparation, an oral suspension of apixaban was made, after the study completed, the EMA changed their regulations around how much propylene glycol was acceptable within oral suspensions for children, and apixaban did not meet those guidelines. So the oral suspension cannot be given to children under 5 years of age, and because of that, I believe that the companies are not going to market the oral suspension. Their workaround was to create 0.5 milligram tablets that could be used for small children. And so I think that's how we're going to have to dose our children if we wish to use apixaban going forward. Now, that's all of the randomized trials, but another interesting study that's just been published within the last couple of months is this cohort study from Christina Vanderplum and the team at Boston Children's, where for a variety of reasons, they made the decision to convert all of their cardiac thromboprophylaxis cohort from long-term warfarin over to apixaban during the pandemic. Because it was prior to the completion of any studies, Christina decided to monitor the drugs, and she aimed for target apixaban levels of 80 to 150 nanograms per mil in patients for primary prophylaxis and 100 to 300 nanograms per mil in patients requiring treatment, with all of those levels taken at 4 hours post-dose. Because this was outside of a trial, she did not have access to the 0.5 milligram tablets. And so this was made by using fractions of the adult size tablets. So for the small children, she either used a quarter or a half of the 2.5 milligram tablet and went with twice daily dosing. So that large cohort study and real world experience has now also been published. I also just wanted to briefly mention that as the DOACs are taking more and more prime place in adult care, then it is more and more likely that we are going to see children who overdose on a DOAC. This table comes from a paper that's currently being prepared as a result of a child who presented to Sydney Children's Hospital who had managed to get hold of their grandmother's apixaban tablets, and a 12-kilo child took 40 milligrams of apixaban, so 8 5-milligram tablets. The child had markedly prolonged coagulation but received no therapy, and within 24 to 48 hours, the coagulation came back to normal and the child never had any bleeding at any stage. So this table suggests that if you actually document an apixaban overdose and you're within 6 hours of ingestion, then administering charcoal is probably a good thing to do. Other than that, you just monitor and then treat on the basis of clinical bleeding. So what am I planning in terms of use of the DOACs? I will always use an initial heparinoid for treating a VTE because that's what all of the DOAC trials did. I plan to use rivaroxaban primarily for VTE treatment, except in the teenage girl population. While it didn't really come out in the trials, I think we are clearly seeing in real-world experience much higher rates of heavy menstrual bleeding in girls exposed to rivaroxaban compared to other agents. Apixaban, I'm happy with for prophylaxis and will probably use it in the very young and also in my teenage girls. At the minute, I'm not using either dabigatran or edoxaban, and that's for two reasons. One, I was less impressed with the dabigatran data because of those issues I spoke about. But two, I think it makes a lot of sense for an institution to try and limit the options for anticoagulation available in treatment. You know, over the last 20 years, we've only ever used one low molecular weight heparin, enoxaparin, and despite the fact that there were other ones on the market, because we just felt in a pediatric institution, a lot of clinicians aren't used to anticoagulation, and having multiple drugs around was just going to increase our risk of an error and a problem. So I'm probably going to push forward with rivaroxaban and apixaban. And I am not going to monitor in standard care, but in situations where I'm worried about absorption or renal clearance or liver disease or at extremes of age and weight, then it may well be appropriate to do so. And I've currently treated now about half a dozen children with short gut who are on long-term thromboprophylaxis for their central line with apixaban, and we've got relatively good absorption on standard doses. And I think the most important thing is that we have to continually review as the studies come out and new real-world data becomes available. I'm going to stop there and thank my team who do all of the research that helps me to get the knowledge and make these presentations. And I hope this has been helpful for you, and I look forward to receiving any questions.